Welcome back to the next lecture. This is going to be psychopharmacology, which is one of my favorite topics. I did all of my graduate work with drugs of abuse. So that means that I had to be pretty fluent in how drugs work, how the body affects drugs. And I think that in general, drugs are a really polarizing subject in our society. So I really like talking about drugs and thinking about drugs. And psychopharmacology is doing exactly that, right? So more or less, psychopharmacology is the study of how, sorry, I'm just trying to move this out of the way a little bit, is the study of how drugs affect behavior. We're also going to be talking about neuropharmacology, which sounds very similar, but neuropharmacology typically is talking specifically about the chemical's action in the biology. So psychopharmacology, as the name suggests, is talking about the intersection between psychology and pharmacology. And neuropharmacology, as the name suggests, is talking about the overlap between the neuroscience and pharmacology. So we have to go over some neuropharmacology because the mechanism of action, which we will define momentarily, of a lot of drugs and how that mechanism actually affects behavior is really important to understanding its behavioral and psychological consequences. So again, psychopharmacology is the study of how drugs affect behavior. Neuropharmacology is how these drugs actually act in the nervous system. And we will be going over both, but we're not going to go over neuropharmacology at such a granular level that that it wouldn't be considered up under the umbrella of psychopharmacology. So I think the first thing to do is try to figure out what a drug is, right? So one thing you probably have noticed throughout this course so far is I spent a lot of time defining terms, and that's a good habit to get into, I think, whenever you're having some kind of academic discussion, because a lot of the terms that we use colloquially are not totally how they're defined in an academic setting. So we have this definition of drug here. I probably got it from APA, but it's any substance other than food that is used. Oh no, I got it from .gov. That is used to prevent, diagnose, treat, or relieve symptoms of a disease or abnormal condition. Drugs can also affect how the brain and the rest of the body work and cause changes in mood, awareness, thoughts, feelings, or behavior. Some types of drugs, such as opioids, may be abused or lead to addiction. So this is more or less a textbook definition of a drug. But a drug is just any kind of chemical that has a receptor binding site and causes some change in the body. Now, the difference between that and there is a difference though between that and food, because food, can have drugs in it, but there is, everything on some level are just chemicals, right? I mean, every single thing is a chemical. At some, you when it comes to biological systems, that is the case. And it's like, you get down to certain levels of granularity and the words start to not really make sense anymore. So broadly speaking, drugs are chemicals that people take for a variety of reasons. And they're not foods, although foods can have drugs in them. So people use drugs every day without really even thinking about it. Obviously there are drugs that we do think about, like nicotine, and most people are vaping nicotine these days rather than smoking cigarettes. But also things like Tylenol, which a lot of people, it's like they knew kind of intuitively that Tylenol is a drug. But when they say drug, a lot of times people don't really mean Tylenol. I mean, I think that if somebody were to say, oh, we caught Bo doing drugs, that would be kind of a silly thing to say if what they meant was, well, we went over to Bo's house and he was taking Tylenol. that would sound a little bit crazy. Whereas if you came over and you saw me shooting heroin, I think that it would be totally fine to be like, well, we don't hang out with Bo anymore. He's a little bit sketch. Like, we went over his place and he was like shooting dope. So, he's a drug dealer. He does drugs. He deals drugs. Whatever the case is, So are drugs bad? Well, no, drugs are not bad. And one thing that I want to kind of talk about is adding some nuance to the discussion of what drugs are, how they work, because there is a large stigma associated with drugs in our society. If you do certain drugs, you're a bad person, you're a criminal. If you do other drugs, then it's not even looked at as drugs. And the reality is that drugs are just chemicals that we use, and some of them have a greater beneficial profile than others. But there's nothing wrong. Like, cigarettes aren't bad. I mean, it's just a thing that people use, and a lot of times it has negative consequences physically. So if you were saying, well, are drugs bad for your health? It's like, well, it depends on what kind of drug we're talking about. So I just want to add nuance into the way that we're thinking about drugs, not to promote drug use necessarily. I mean, I don't know that I promote drug use. I'm just saying that, like, it just depends on the drug. I mean, if you have cancer and you need to smoke weed to eat, then I would say that that's probably a good application of that drug. If you have cancer and chemotherapeutics can slow the acceleration of the cancer, then that's a good drug. If your goal is to live till you're 80, then smoking cigarettes would be a bad idea. And I would say that in that scenario, nicotine is a bad drug. If you don't want to be addicted to a chemical, then I would say nicotine is a bad drug if you don't want to be addicted to something. If you don't mind being addicted and you like how cool mint and peach berry tastes, then I guess it doesn't really matter. It just depends on what you're trying to do, what you're trying to accomplish. And people use drugs all the time. Drugs are everywhere. I mean, we sell them constantly. I mean, drugs can be found in foods, like I said, like in alcohol. Alcohol and ethanol. Ethanol is the drug that you find in alcoholic beverages. And it's in itself, it's a really interesting chemical because it has properties of foods in of itself, even outside of the fact that it's in foods, right? So if we were to consider this like beverage that has a caloric value to it in carbohydrates, it also has ethanol, which is the drug. So if you're drinking, you're doing drugs. Like that's one thing that really irritates me. People look at Coke as doing drugs and drinking as like not doing drugs. It's like alcohol and drugs. Like there's not two categories here. It's like you are doing drugs if you're drinking alcohol. But it's an interesting blurry line because ethanol has calories itself. So it's almost like a separate macronutrient, but due to the fact that it has such clear effects at certain receptor sites, it's obviously also a drug. Coca-Cola. If cigarettes are drugs, then Coca-Cola is a drug, right? Because technically in the scenario of cigarettes contain a drug called nicotine, right? So cigarettes in themselves are not nicotine, but the active ingredient in cigarettes is nicotine. Same thing with vapes, right? So if you're going to consider cigarettes themselves drugs, then Coca-Cola is also a drug. But realistically, the drug in Coca-Cola is caffeine. If you're drinking Coca-Cola, you are doing drugs. If you are drinking alcohol, you are doing drugs. If you're taking Tylenol, you're doing drugs. If you're smoking cigarettes, you're doing drugs. Why am I belaboring the point? It's just because there is this really naive way that our society views chemicals, and chemicals are just chemicals. They're not bad or good. Some have good consequences. Some have bad consequences. Here's Starbucks. Do drugs in all sorts of different colors and flavors. Why not? But caffeine obviously is the drug here. Natural products are drugs also. Okay, so this is one thing that I find incredibly frustrating. I have no problem with weed. If people want to smoke weed, like, that's cool. Do whatever you want to do as an adult. I don't really care what you're doing. But there's this idea, again, that I think comes from the stigmatization that we have about drugs in our society, that weed is somehow not a drug. Weed absolutely is a drug. It contains tetrahydrocannabinol, which is THC. It's the active compound found in weed. And just because it's a plant and comes from the earth doesn't mean that it's not a drug. There's this idea that drugs are just made in a lab. I don't know if so much in this generation, if that's something that people even talk about. Maybe this was just like something that was true in previous decades because weed was illegal, and now that it's becoming much more legal, maybe people aren't like, coping so hard. But back when, I was in my 20s and my teens, all of the potheads were like, bro, like, we're not doing drugs, like we're smoking weed. Weed comes from the earth, like it's a plant, it's a medicine, whatever, dude. I don't care what you call it. It's a chemical that affects your nervous system, and so therefore it's a drug. But not only does weed come from the ground and a plant, so does heroin. This is the poppy plant right here, and so does cocaine. This is a coca plant. So most drugs like cocaine or heroin are derived from plants. Now, of course, we have drugs like methamphetamine, which are not directly coming from plants. Drugs that come from plants are called natural products, which is right here. And that'll most certainly be a test question, is that, there'll be something like, true or false, drugs only come from a lab or something like that. Natural products are some of the most potent drugs that we have. A lot of really good drugs are derived from natural products, and by good I just mean potent. So or effective at whatever it is that we're using them for. They're tools. So yeah, natural products are drugs, not just made in a lab. Methamphetamine is a drug, THC is a drug, opium is a drug, cocaine is a drug. All of those except for meth come from plants, so whatever. Psychoactive. Some drugs are psychoactive, but not all. So psychoactive means that it affects the mind. It doesn't necessarily mean that it affects the brain, right? So that's why we talked about that kind of exhaustively in the first lecture, and why we spent so much time talking about the mind and the brain separation. Because when we're talking about psychoactive drugs, we're not just talking about drugs that may or may not have an effect on nitric oxide expression in the brain. We're talking about whether or not the drug itself can affect perception, mood, and behavior. So we have certain drugs, like psychoactive drugs like caffeine or THC or alcohol or psilocybin, which is the active ingredient in shrooms or magic mushrooms, heroin, cocaine, SSRIs, which are selective serotonin reuptake inhibitors, which we'll talk about, anxiolytics, which are anti-anxiety drugs, which are like Xanax or Ativan or Valium, those kind of things. And then we have like mood stabilizers as well, like what's it called? The drug for bipolar disorder. I can't think of it right now, but several of you are probably very irritated and screaming at me what it is. Thank you, whatever that is. And then we have non-psychoactive drugs like Tylenol and ibuprofen and antibiotics. Lithium is what I was thinking, by the way. Mood stabilizers like lithium. Antibiotics, chemotherapy, steroids. Steroids can be tricky because there are steroids that have psychoactive properties, or that can kind of have secondary psychoactive properties. I put them in the non-psychoactive drug though, because it's not like with psilocybin where it's like if you eat shrooms, like you're going to have a trip, versus steroids. If you're taking testosterone, it could have an effect on your mood. If you're taking trenbolone, you can have some deleterious psychiatric outcomes as a result of taking that, but it's not typically thought of as a psychoactive substance. Just looking at my notes, seeing if there's something else I want to talk about. Pretty sure. Physiological effects. Yeah, so, non-psychoactive drugs like Tylenol or ibuprofen or antibiotics or steroids or chemotherapies, they're used to treat some kind of physiological problem. Tylenol and ibuprofen, although they have different mechanisms of action, which again I have not yet defined, but I will, are used to treat pain. Antibiotics are used to kill harmful bacteria. Chemotherapy is used to halt the process of certain cancers, and steroids are used for people who have a deficiency in some kind of hormone. Also, maybe I should just touch on that really quick, just because it's a really big problem with it's always been an issue, but I think that social media with fitness influencers have really changed the way that we view steroids. So a lot of influencers are open about their steroid use these days, which I think is good. I think transparency is good, but steroids are just talking about normally exogenous hormones. So if you're taking testosterone replacement therapy, you're doing steroids. If you're taking a low dose of there's that really, I can't remember the name of the drug right now, but basically my point is that if you're taking exogenous hormones, you're doing steroids. Now, again, saying that you're doing steroids has a negative stigma to it, just like saying you're doing drugs has a negative stigma to it, but steroids are not inherently bad, and people who are deficient and have wasting diseases really need steroids in order to maintain any kind of quality of life. Women need hormone replacement therapy at various times in their life. Men need hormone replacement therapy at various times in their life. But, if you're in your 20s and you're taking testosterone and it's at replacement dose levels or whatever, you're doing steroids. We don't need to lie as adults about what it is that we're doing. So what the body does to the drug. Okay, right. So pharmacokinetics. So there are certain categories that we need to know of what they're talking about. So we're moving now on from what drugs are, what psychoactive is. You need to know what psychoactive is, by the way. I'm sure I will ask a question about, what are examples of psychoactive drugs, all of these, what are examples of non-psychoactive drugs, these ones. You could also think of other ones, but probably I'll just list whatever it is that I have here in the lecture. Natural products, you'll need to define. Drugs can be in foods, you'll need to be able to know that. I don't know if I will ask about whether or not drugs are bad. That's just kind of my PSA here. So we also have certain vocabulary terms about how drugs interact with your body and how your body manipulates drugs. So pharmacokinetics is referring to what the body does to the drug. Okay, so when you take Tylenol, you swallow it, it goes to your gut, your stomach acids start to dissolve it. It is then processed by your liver and your kidneys, and then after all of that, which is called first pass metabolism, then it gets into your bloodstream and then it can have an effect. So metabolism, which is essentially what your body is doing to the chemical, whether it turns into another chemical once it's in your system or maintains its structure before that. So if you hear of certain metabolites of a particular drug, that's saying that the drug after metabolism is broken down into these metabolites or other types of a drug, and it may be something totally different, a different compound that has a different effect, but that's what people are talking about when they talk about metabolites. Or absorption, the ability of your body to absorb a chemical or a compound in a particular setting is a pharmacokinetic property. So it may be the case that the drug that you're taking can't be absorbed in the stomach lining or whatever, so you have to take it topically or you have to inject it intravenously or something like that. But if you're able to absorb it in a particular way, this is a pharmacokinetic property. Distribution, the ability of that drug to then go to different places in the body or to travel. Excretion, obviously your ability to then get rid of the drug. These are all pharmacokinetic properties that outside of this list I'm not going to ask too much about, just because I don't know that much about pharmacokinetics. that has a lot more to do with the pharmacology, again, of how your body's metabolizing and using this stuff on a physical level. And then there's pharmacodynamics, which we will be talking quite a bit about because that's what I know more about. So what the drug does to the body, right? So we have pharmacokinetics, what the body does to the drug, again, metabolizing the drug or getting rid of the drug. And then we have pharmacodynamics. And also really quickly for pharmacokinetics, you can try to remember which one is which because kinetics sounds, now this isn't actually what the root word is, but for me, it sounds like kinesiology in some way. And kinesiology is the study of the body. So that's why pharmacokinetics, I always know, is talking about what the body does to the drug. And then we have pharmacodynamics. This is what the drug does to the body. So the mechanism of action. This is referring to, I'm actually going to define that on the next slide, so we'll save that. We have affinity, efficacy, potency, an ED50, a TD50, sensitization, and tolerance. We'll go through each one of these bullet points. But certainly you'll need to know that pharmacokinetics is what the body does to the drug. You'll need to know that pharmacodynamics is what the drug does to the body. So mechanism of action in pharmacology is referring to what the ligands are doing to their receptor sites. So let's see what in pharmacology, drugs and chemicals in general that bind to receptors are referred to as ligands. You all should know that already because I defined that in like the synapses lecture. The vast majority of drug effects are driven through the interaction of ligands and receptor binding sites. So that's what mechanism of action is normally referring to, is where the drug is having its effects in the body. So all drugs have a mechanism of action or an MOA. The mechanism of action is referring to how the drug induces its effects physiologically. So we have two examples here. I've defined both of these in the previous lectures, I think at the chemical synapses lecture, or the chemical events at a synapse. But we have agonists and we have antagonists. Agonists are going to bind into a receptor binding site, and then they're going to cause that receptor to have an effect, right? So if you have glutamate is going to bind to a glutamate receptor and is going to cause that glutamate receptor, if it's an AMPA receptor, to allow the influx of sodium. It's going to bind to the receptor binding site. That protein, which is the receptor itself, is going to have some kind of conformational change, because of the receptor binding to it. That conformational change is going to allow the influx, in this case, of sodium, right? Antagonists, you can see that the way that they're describing this is that, it has a similar shape to the agonist, but it's going to not actually have the effect that a receptor agonist would have. So it can still bind to the receptor site, but it actually can't activate that receptor. So a good example of this is Narcan, which is a opioid antagonist that has, we'll define it momentarily, but extremely high affinity. And so what that means is that the receptor, the agonist, will bind to the receptor, and it's like a magnet. When it has high affinity, that means that it's got extremely high binding potential to the receptor. So you have certain antagonists, which in this case of Narcan will bind to the receptor, mu opioid receptors, and it will actually kick off opioid agonists like heroin or morphine or whatever opioid agonist is, in the person's body. The affinity of this antagonist is so high that it kicks off the agonist. And now, since it's binding to that receptor but can't activate the receptor, you negate the effects of that receptor site. So in the case of heroin overdose, opioids bind to mu opioid receptors, and there's a lot of mu opioid receptors in certain breathing centers of the brain. I think we went over that in neuroanatomy potentially. And it causes respiratory depression. So when somebody's dying from an opioid overdose, it's because they literally just stop breathing. And so if you give them Narcan, it has such a strong binding potential to the opioid receptor that it kicks the opioid receptor off, and then it actually, will allow them to start breathing again. So this is agonist and antagonist, and certain drugs, their mechanism of action is an antagonist at the opioid receptor, like Narcan, or they could be an agonist at the opioid receptor, like heroin. Did I already say this? All drugs have mechanism of action, yeah. So we have cocaine is a dopamine transporter blocker. Adderall blocks and reverses dopamine transporters. Heroin is an opioid receptor agonist. And I'm going to talk about this again, but this is why I get really frustrated when people have certain opinions about certain types of drugs, and not just about illegal drugs, like, with GLP-1 agonists and Ozempic. A lot of people have a negative idea of Ozempic. It's like Ozempic is just a GLP-1 agonist. That's all it is, right? So if we know what the chemical does and we know what the receptor does, there's nothing to be scared of, right? Like, we test the drug, we see what the side effects are, we look at the profile of its potential toxicity and its potential benefits, and then we use the drug if we think that it's going to be a beneficial tool overall. So, cocaine and Adderall have very similar mechanisms of action, but one of them is illegal and one of them is used as a prescription drug every day. So, understanding how a drug works is very important. So, I've already defined affinity a little bit, but affinity is the level of specificity that the drug has for the receptor. So let's say that we have a couple of different receptors here, we have a couple of different drugs, and we can see here that drug X can bind to receptor 1 and receptor 2, and then drug Y only binds to receptor 3. So this is trying to demonstrate this concept that I talked about earlier with the opioid antagonist thing, which is that when you have high affinity, that means that the specificity of the drug and the level of attraction to that receptor that the drug has is that's what affinity is talking about, rather. So if you have a drug that has very high affinity, that means that the drug has an extremely high binding potential to the receptor. So we can see that for drug Y, it has a very high binding potential for this third receptor, receptor 3. If we look at drug X, it may have high affinity for receptor 1, and it may have okay affinity for receptor 2, but there might be a drug that fits receptor 2 better than, this drug X does, in which case, the affinity might be lower in drug X than to some other drug that fits receptor 2 better. Similarly, like, the affinity for drug X and receptor 3 is just non-existent. It won't fit in receptor 3. So affinity is the level of specificity the drug has for a receptor, and the binding potential that it has. So if I were to say, there's some drug that kicks another drug off of its receptor site, this is an example of what? And the answer would be high affinity, or the fact that this drug has a higher affinity than the other drug. So certainly I'll ask you about affinity, because it is very important and it is tied directly to efficacy and potency as well. So before I define efficacy and potency, I have to first show you what this dose response curve is. So if you don't understand affinity, then rewatch this section a couple times. But we have dose response curves, which are how we measure almost like everything in pharmacology. So a dose response curve is also called a sigmoidal curve, or realistically dose response curves are often sigmoidal, but sigmoidal is just referring to a characteristic S shape in a data set. So you could see sigmoidal curves all over the place, and they don't always have to look like this. Sometimes you could have a sigmoidal curve where the S is going in the opposite direction, where it starts off really high and then it goes down in the opposite direction that this S is going. But a sigmoidal curve is, it looks like an S. That's how you can remember sigmoidal and S. And then, we have a typical graph here, which you'll see often in pharmacology and in behavioral pharmacology, which is what is most directly applicable to psychopharmacology. We have some kind of behavioral response on the y-axis, which in this case is steps. And then we have on the x-axis a dose. So that's why it's called a dose response curve, is because on one axis you have a certain dose, and on the other axis you have a certain response. Okay, so if we were talking about shrooms, you would have dose and trypin. If we were talking about anxiolytics, we would have dose and decrease in anxiety. Here I was envisioning doing meth or something, or some kind of psychostimulant. And if we have dose over here and then we have steps over here, the more meth you do, the more you're probably going to walk around. And I'm just using those trigger words just to wake people up, because I was starting to get bored of my own self talking. And so I was like, oh my God, like if I'm getting bored of my own self, then you guys are probably super bored of this. But in any case, that is what a dose response curve is. It's a sigmoidal curve. It has an x-axis, a y-axis, like all graphs do, but it's going to show a dose-response relationship. And we use sigmoidal curves in pharmacology and in behavioral pharmacology to measure things like efficacy and potency. So efficacy is the maximum possible effect. Okay, so these concepts, efficacy, potency, and affinity, they get so confused all the time. And so I'm going to spend some time really trying to tease them apart. So, and also you should spend time on this, because it's just such an easy question to get wrong when I ask about efficacy and potency and affinity. So affinity is the most outlier of them, but affinity can directly affect efficacy and potency, which is why people get confused and they kind of sound similar. And in fact, I think even I wrongly said efficacy earlier as affinity. But yeah, so we have efficacy, which is the maximum possible effect that a drug has. And then we have potency, which is the amount of a drug needed to produce a maximal effect. So you can see why just saying this drug is stronger than this drug is not totally informative, because you could say that a drug is stronger than another one because it has higher potency, or you could say that it has higher efficacy. So here are two examples of two different drugs, right? One of them has higher potency, the other one has higher efficacy. So let's go ahead and look at drug A. Drug A is more potent than drug B. Okay, so what's potency mean? It's the amount of drug needed to produce a maximal effect. And if we look at this dose response curve, and we look at the dose on the x-axis and the clinical response on the y-axis, or also the efficacy, we can see that you only need to take 5 milligrams of drug A to equal the same output of 50 milligrams of drug B, right? So that's potency. They both are kind of referring to strength in some way, but potency is talking about how much of the drug you need to take in order to get a specific effect. Now let's look at efficacy. Efficacy is the maximum possible effect. So although drug A is more potent, it's not as effective, okay? Because as we can see, the top of the sigmoidal curve is referring to what the maximum effect can be for that drug. So we only have a 50% clinical response in drug A. Whereas in drug B, we have 100% of clinical response or efficacy. So although, we could take drug A and we could take 5 milligrams of drug A and get the effect of 50% of drug B, which we would have to take 10x the dose to get, we can never get the same outcome that drug B has to provide. So an example of this is actually on the next slide. We're going to talk about different opioids, but also like with pain relieving properties with opioids and something like a non-steroidal anti-inflammatory like ibuprofen, where, you know, although now the analogy breaks down because ibuprofen is not more potent or more effective, you know, than opioids. But the point is that the maximal efficacy of something like Tylenol or ibuprofen is not even going to come close to the maximal efficacy when it comes to pain relief that like opioids provide, like heroin or morphine or codeine or you know, OxyContin or what's the one that's popular these days? I have too many drugs in my brain. I can't remember all the names. Fentanyl, right? So anyways, drug B is less potent but more efficacious. Drug A is less efficacious but more potent. So I know that's confusing. Please try and spend some time with this, because I will give you, I'm going to go ahead and state it now to hold my future self accountable. A question in the exam will be looking at this graph and pointing out which drug is more potent and which one is more efficacious. Okay, so let's go ahead and look at another point here. This is kind of what I was talking about momentarily. We have a couple of sigmoidal curves here: hydromorphone, morphine, codeine, aspirin. And we can see that the drugs that are more potent are the ones that are going towards the left of this dose response graph. And that's because as we go left on a dose response graph, typically that's going to be associated with a lower dose. So we can see that hydromorphone and morphine have essentially the same efficacy, right? Because they both, let's see what the y-axis is, percentage of elevation in pain threshold. I don't know why they would say it like that. That's about the most confusing way I feel like you can say it, but this is talking about pain relief. So if you have an elevation in your pain threshold, that essentially means that you can tolerate more pain, which is also basically the same thing as saying that you have less pain, right? So anyways, they're talking about the analgesic. Analgesic means pain relieving properties of hydromorphone, morphine, codeine, and aspirin. So we have 3 opioids here. We have 2 that are more potent. We have hydromorphone, which is the most potent. It's more potent than morphine, but it has a similar efficacy as morphine. So if that doesn't make sense as to why that's the case, then please try and make sure you understand why I'm saying this. That hydromorphone is more potent than morphine because it takes less of a dose to get the same effect that morphine has, right? So it's like, in order to get 50% pain reduction, with hydromorphone, you only need to take 5 milligrams, right? But with morphine, in order to get the same level of analgesia, you have to take 10 milligrams of morphine. However, they have the same effectiveness because they both provide up to 100% pain relief, or whatever this, you know, pain threshold metric is referring to, 100% analgesic or whatever. Codeine, on the other hand, is slightly less efficacious. So it still gets very close to the same level of efficacy that hydromorphone and morphine have, but it's far less potent. So we can see here that on this dose response curve, in order to get the same pain relieving properties in codeine that hydromorphone has, you have to take 100 milligrams compared to taking only 5 milligrams. Or whatever this dose is. It's hard to see. I don't exactly know if this is 2 or 5 or what this dose would be, but point is the same. And then we have aspirin, which is just like terrible compared to all these other ones as far as analgesia goes, which is that the potency is far less than all of them. I mean, in order to get even, you know, like the smallest amount of pain relief that hydromorphone offers at 1 milligram, you have to take 100 milligrams of aspirin, right? So the potency of aspirin is terrible compared to all of these opioids, and its efficacy only maximally produces 75% of what the other ones produce, right? So now There's a reason why you would take aspirin, which is its safety profile, which we will talk about momentarily. Because while these other drugs have extremely high efficacy and potency in regards to pain relief, that also means that they have extremely high efficacy and potency for respiratory depression, likely. So this was a continuation of me describing efficacy and potency. But this slide header is called effective dose 50, or an ED50. There's two ways of defining ED50. And when I ask about this on the exam, I will make it clear in the context of the question which way I'm talking about ED50. The first definition of ED50 is that I have written right here, which is the ED50 of a drug is the dose at which the drug produces 50% of its maximal effect. This is often used to look at the different potencies of various drugs. So if we say that the ED50 is 50 milligrams or the ED50 is 100 milligrams in codeine, that means that when we take 100 milligrams, we will get 50% of its maximal effect based on that dose. So ED50 in the first context is talking about the effective dose, which is how you measure potency. So you look at the ED50 of hydromorphone, you say it's 2 milligrams. You look at the ED50 of morphine, you say it's 10 milligrams. You look at the ED50 of codeine, it's at 100 milligrams. It's at 100 milligrams. The ED50 of aspirin is going to be at like 150 milligrams. It's off the chart here. So that's the first context for ED50. The next context of ED50 is looking at a therapeutic index. So you will definitely need to know the effective dose, ED50, and you'll need to know about a therapeutic index. So the therapeutic index, which is called the TI, is produced by dividing the toxic dose 50 and the effective dose 50. And in this context, ED50 is saying the dose at which 50% of the treatment population will get the desired effect. So there's also something that we're not going to go into, I don't think, but basically there are different genetic predispositions that produce different efficacy and potencies with certain drugs. So that's all I'm going to say about that, because honestly I can see that we're already 43 minutes in and only halfway done with the slides. So I got to hurry up here. But that's why there's two different definitions of ED50, is because one of them is looking at the dose at which 50% of the treatment population will get the desired effect. So that means that 50% of people, so in this dose response curve, we have a percentage of responding. So that's the dose at which people respond and how high they respond to these various effects. And we have three effects of the drug, which is anxiety reduction or an anxiolytic effect. We have sedation, which is like actually being tired or something. And then we have respiratory depression, which is referring to you not breathing anymore, right? So your respiration being decreased. And we see here that on the x-axis, we have a margin of safety. So that's how we're deriving our therapeutic index, is looking at like, okay, well, we have this drug in blue, and we're saying that 50% of the population will have reduced anxiety at this dose here. Let's just say that it's 5 milligrams. But there's a toxic dose here at 10 milligrams. And the toxic dose can be referring to whatever the side effects that we don't like are. So that's why drugs are not just like good or bad. It's like, drugs are chemical compounds that have outcomes in our physiology, right? Some of them are good, like in this case, reduced anxiety. Some of them are bad, in this case, sedation, because maybe we can't get off the couch or do anything. And some of them are fatal, because in this case, we're talking about respiratory depression. So when we're talking about a therapeutic index for sedation, we may say, okay, well, the effective dose for this drug for reduced anxiety is, over here at 5 milligrams, but the sedation toxic dose is over here at 10 milligrams. So your margin between when you get a reduction in anxiety and then when you also get sedation are really close together. So that might not be good, because if you have somebody who has chronic anxiety who needs to take anxiolytics every day, if the main way that they're getting that reduction in anxiety is through sedation, then that means that they're not going to be able to drive automobiles potentially, because, they have some kind of anxiety disorder. They can't get out of the house because of the anxiety. So you give this medication, but then it also makes it so they're so sedated that it's not safe to drive anymore, right? So that you have to be mindful of. But then we also have this toxic dose 50 referring to the respiratory depression. And, you may end up dead if you take, because 100% of respiratory depression means that you're not breathing, right? So you may end up dead with 50% respiratory depression, which means that your toxic dose 50 for this compound might be 100 milligrams or something. So the ED50 is the dose at which 50% of the treatment population will get the desired effect, meaning that if 50% of the population that takes the drug takes 10 milligrams of that drug, they will get a reduction in anxiety, right? The toxic dose is the dose at which 50% of the treatment population will get the undesirable side effect. So the TD50 of this drug would be, 10 milligrams for sedation, and it may be 100 milligrams for respiratory depression. And the therapeutic index is the ratio of the toxic dose to the toxic dose 50 to the effective dose 50 of some desired outcome, right? So you always have to balance, again, what your desired effect is, in this case, reduction in anxiety, and what you're trying to avoid, which would be death or a certain level of sedation. And that's how you derive a therapeutic index. And that's why some drugs, it makes sense for some drugs to be prescribed while other drugs are not prescribed. So it doesn't make sense for people to be able to go buy fentanyl, because fentanyl's effective dose and its toxic dose are too close together. It's way too easy to kill yourself with fentanyl and heroin and a lot of opioids. So that's why most opioids, except for like Imodium, which can't cross the blood-brain barrier, are prescription drugs only. It is because their therapeutic index is not super favorable, and you can't trust the general population with that. So by analogy, you could think of like a firework. You know what I mean? Like there's reasons why fireworks are illegal, but like hand grenades are not. It's like you could conceivably use a hand grenade safely, but the consequence of not is very high, and it's very easy to accidentally not use a hand grenade properly, right? So it's similar with this, which is that drugs that have a very strong outcome and some undesirable effect, like respiratory depression, if it's really easy to kill yourself because you're trying to get to an analgesic threshold, but that analgesic threshold is near a toxic threshold that could wind up in death, then these drugs need to be prescribed to protect the general public. And that's why we see a lot of deaths with fentanyl and things like that, just because the TD50 is so low. So hopefully that was not super confusing. You'll need to know what produces a therapeutic index in the exam. So you'll need to know that TD divided by ED equals TI. You'll need to know this little equation here. You'll need to know that in this context, ED50 is referring to the dose at which 50% of the treatment population will get the desired effect, not the previous definition here. And you'll need to know that a TD50 is referring to the dose at which 50% of the treatment population will get the undesirable side effect. And this is nuanced because it's not just talking about respiratory depression or death, it's also talking about sedation, right? So it's just the toxic dose is simply referring to the effect of the drug that we don't like, right? So drugs could have many different types of TD50s depending on which kind of effect we're trying to avoid. Okay, so let's talk about sensitization. Sensitization is technically defined as a leftward shift in the dose response curve. So here we have our meth example again, where someone's getting spracked out, taking meth, and sensitization to the drug means that the more you take the drug, the more the higher the potency for a particular effect becomes, right? So I'm trying to use the vocabulary word that we just defined, but basically, if you take the drug multiple times, this dose response curve shifts to the left. What does that mean? That means that the same dose A that we took on day 1, that only gave us, it only made us walk 10 steps. On day 5 of our meth binge, that same dose is now making us walk 5,000 steps. So I have it broken down here. Less drug equals same effect, or same dose equals stronger effect, right? So if you were to take dose A, you get effect A. If you were to take dose A after sensitization, you get effect B, right? So this is becoming more sensitive to the drug, as the name suggests. But technically, it is a leftward shift in a dose response curve. Tolerance is exactly the opposite of sensitization. So technically speaking, tolerance is a rightward shift in the dose response curve, meaning that more drug equals the same effect, or the same dose equals a weaker effect. So in this scenario where our meth binging person is becoming tolerant to the stimulant effects of the drug, they may take 50 milligrams at day 1 and walk 5,000 steps, and then they take that same dose on day 5 and now they only walk 50 steps. Similar to there being a variety of different toxic effects that a drug may or may not have, you can become sensitized or tolerant to different effects of the same drug. So you may develop a sensitized responding to the craving of a drug, but tolerance to the hedonic or the rewarding effects of a drug. And we have a whole lecture on drug addiction and substance use disorder where we'll talk about that, but that's one of the main theories behind drug addiction, is that you become sensitized to craving and tolerant to reward. And that results in a positive feedback loop where you're taking more and more drug to try and get a previous effect, while all the while craving the drug more and more. Okay, so moving on now from that portion of pharmacodynamics, now we're going to be talking about routes of administration. And routes of administration, or the ROA, is referring to how you get a drug into your body. Now, this is another misconception. You'll hear people at times say they've done all drugs except needles. And so generally what they are referring to is that maybe they said they did coke, they did meth, people normally associate like heroin or opiates with needles. And that's largely because of the way that they're portrayed in movies. But injecting a drug with a needle is just a way, generally speaking, of doing an intravenous route of administration. So you can inject almost all drugs, assuming that you can put them into a liquid state. You can smoke many drugs, assuming that the fire doesn't just immediately destroy the drug, so that's why you smoke crack. Crack is just cocaine. It's just a version of cocaine that has been changed in a way that allows it to be, I'm not sure what it's called, not vaporized necessarily, but it allows you to put flame onto the drug and turn it into smoke so you can inhale it. If you do that with just powder cocaine, then the cocaine just melts before you can get enough smoke to inhale it, right? So you can do just about every kind of route of administration with any type of drug, assuming that the chemical itself is amenable to that route of administration. So you can smoke heroin, you can shoot heroin, that's why people used to smoke OxyContin. You can't do that now because of the way that the pills are formulated. They won't release the smoke anymore, but you could smoke pills at one point. think most abusable drugs that come in pill form now aren't really smokable. You also can't really snort them anymore either, because like they won't crush up properly. Like if you crush up certain opioids, like it doesn't become a powder anymore. So when you snort it, you just end up swallowing it. But route of administration is talking about the different ways that you get the drug into your blood system, or you get it to wherever it needs to go to have its effect. Generally speaking, though, especially in the context of psychopharmacology, we're talking about getting that drug to the brain. And in order to get it to the brain, we need to get it into the blood. So we have intravenous injection, which is going to be into the venous system. It's going to go into the heart, through the lungs, and then eventually to the brain. We have inhalation, where you inhale it, it goes directly into the lungs, and then from the lungs, it goes into the blood, into the brain. And then I have here systemic and local. So systemic means drug is circulating into the entire system, whereas local means that the drug is being restricted to a specific site. So these are all the various methods of administration that I think these are all of them. I was just looking for, intrathecal is probably a rare one. But anyways, these are all the routes of administration that we can do. We're going to go through some important ones. So oral or PO, this is swallowing some kind of a drug and absorbing it through the gut. And like I said, similarly with effects, there's pros and cons to all of the routes of administration. So pro is that it's safe, it's easily self-administered, and it's economical. So you can just give somebody a pill. You can formulate that pill so you know how much of the drug is actually going to get into the blood based on an average person's metabolism of that pill. But there's some cons to it, which is that it's slow, variable absorption, has to go through first pass metabolism, it's less predictable levels in the blood, right? So it's like, although you can be fairly confident that they're not going to overdose on it, the flip side to that is that it's not quite as clear how much of that is going to get into the blood, because you're going to lose a lot of that through metabolism. So I also define first pass metabolism here, which is drug has to pass, I kind of mentioned it earlier, but drug has to pass through the liver before getting to the blood, which may destroy the drug or reduce some of its characteristics. So the liver is going to filter out a lot of chemicals before they get into your bloodstream. So that's what first pass metabolism is. And if you take it orally, then you're going to have to deal with first pass metabolism. We also have intravenous drugs, which are injection of the chemical directly into the venous system. So this is the most rapid, most accurate blood concentration. If you're pulling back a certain number of milligrams, you know that amount of drug is getting into this person because you're taking 10 milligrams and you're injecting it directly into their blood. You know they now have 10 milligrams in their system. But a downside is that overdose is easier because it's not going through that first pass metabolism. So you can just inject a whole bunch of drug into you, and if you are not tolerant enough to that, or if it's the wrong dose, you're basically going to die immediately. It's not easily reversible. It requires sterile needles and medical techniques. So there's a lot of barriers to entry. A lot of people don't like injecting themselves at all, let alone intravenously. So you can inject yourself with a needle intramuscularly, which would be far easier, and that's how a lot of people do steroids, is that they will inject themselves in their butt or whatever into a high muscularly dense piece of tissue. But intravenous means that you're taking a needle and you have to actually hit a vein, which can be painful and also kind of gross, and people don't like it. So it is probably the best way to get the drug into your system, as far as like the pros are saying, it's the most rapid, most accurate blood concentration, but it's also, a lot of people don't want to do that. It's a pain in the butt, and also you can overdose super easily. So if you are wrong about the dose that you need, then you're going to have a bad time. All drugs, assuming that you can get them into a liquefied form, can be injected, not just heroin, as I've already kind of belabored that point. We have intramuscular, which is IM injections, which is directly into a muscle. So it's slow and even absorption, but the problem is that's localized. irritate the site of injection, and you need sterile equipment. Again, a lot of people don't want to do needles, so like Ozempic, I think, is a intramuscular injection. I could be wrong about that, but it's definitely requires a needle. And it can also kind of hurt, injecting directly into a muscle, like when you're getting vaccines and your arm is sore for the rest of the day. We have subcutaneous, which is injection of drug directly below the skin. So I'm actually not sure of a drug off the top of my head that requires subcutaneous injection, but there's a variety of them. The pro to this is that it's slow and prolonged absorption. A con is that it's got variable absorption depending on blood flow. So if you get it in an area where there's not a lot of blood flow, then the amount of drug that's actually going to pass into your vasculature is going to not be super reliable. So we also have inhalation, which is vaporizing or turning the compound into smoke and taking the drug into the lungs. Pro to it is that it's a very rapid onset. It's almost as fast as intravenous injections. And there's a large absorption surface, and there's no injection equipment needed. So a lot of people are much more okay with inhaling some kind of drug versus injecting them. We also have topical, which is the application of drugs to the mucosa membrane, like the eye, oral cavity, nasal passages, vagina, colon, urethra. Generally provides some kind of localized effect. Some pros to this is localized action and it's easy to self-administer, but some cons would be that it's absorbed, maybe absorbed into general circulation when you don't want it absorbed into general circulation. We also have transdermal, which is like using a patch. So it's transmitted through the skin, generally in the form of a patch or whatever. I already said that. It's controlled and prolonged absorption. So that's good if you need to have like some kind of slow drip of a drug over the course of the day, but it can also cause local irritation, and it's only useful for lipid soluble drugs. So it needs to be a drug that has the kind of property where it can be absorbed through fat. Which can be a con. Epidural, which means injection above the dura directly into the CNS. So this is when they're giving an injection into your spine, right above. Epidural means above the dura. So the good thing about this is that it bypasses the blood-brain barrier and has basically rapid onset almost immediately, but it's not reversible. So that can be a very big problem if it's a too high dose and you need a trained anesthesiologist. So obviously, you're not going over to your homie's place and just getting somebody injecting you in the spine. You're going to need somebody who is trained, and even trained anesthesiologists can mess up and cause nerve damage. So, getting an epidural, normally that's what you refer to it when you're giving birth. You're getting an epidural injection is what's actually happening. It's not the name of the drug. But there can be consequences. You can miss. You can get in the wrong spot of the spine. You can cause issues. But I would suggest getting one if you have the ability to. Intranasal, obviously, would be snorting or sniffing a drug in the form of powder or spray. It's absorbed through a thin layer of epithelial tissue into systemic circulation. So certain types of tissue, like in your nose and also underneath your tongue, you have smaller or more thin epithelial tissue, so it can be absorbed into the blood this way. So it's easy to do, local or systemic effects, rapid, no first pass metabolism. It bypasses the blood-brain barrier because it's going directly into the bloodstream. So those are all good things. So these are a lot of different routes of administration. One thing that I will ask you for sure is about intravenous infusions, because I think that's kind of important. I want people to know that heroin is not just a drug that you inject, it's also one that you can smoke. So this is a drug that, people shouldn't be confused about, like what this all means. So IV, you should know. I will talk about, obviously, oral. We will have to know about subcutaneous and intraperitoneal. Did I not define IP? I didn't. So you won't need to know IP. So you'll just need to know the ones that I have here: oral, IV, IM, subcutaneous, inhalation, And I doubt that I'll ask about the other ones other than maybe intranasal. So drug classes. Drugs are categorized by their mechanism of action. And we are coming up, we're at an hour, but we are almost done. We're at 34 of 43 slides. So we are very close to being done, assuming that I can stay focused and not go off of tangents too much. So drugs are categorized by their mechanism of action and or effects. That's what gives a drug its class. You know what I mean? So if we're talking about opioids, if we're talking about depressants, if we're talking about stimulants, it's being referred to that based on its psychopharmacological effect. You know, so what kind of effect it's having on your mood or your behavior. Is it making you hallucinate? But also how, like, its receptor binding site. So here we have opioids, which are drugs that are produced from the poppy plant and are derived from the drug opium. We have prescribed opioids like Vicodin, Norco, Percocet, Demerol, etc., all the way down to even oxycodone and fentanyl. And then we have an illicit opioid here, heroin, which obviously illicit means illegal. Opioid, there are 3 main opioid receptors. There's more than that, as there always is more complexity than what we will go over, but these are the ones that you need to know. Mu is commonly agonized by opioids that are used for pain relief and produce addictive-like results. So when somebody's high on opioids and they have the hedonic effects produced by those opioids, it's thought to be through the mu receptor. So if something is a mu receptor agonist, like heroin is, then it probably has a lot of addictive-like properties, and it also is going to cause pain relief. Now, we're going to go over the difference between dependence and addiction and substance use disorder in our substance use disorder lecture, but we'll just leave it to addictive-like results here for now. It can also produce cardiovascular and respiratory depression, so it can be also categorized as a central nervous system depressant. It has cough control, and nausea and vomiting are also symptoms. So it controls your cough, and it will cause you to vomit. We also have delta receptors, which also produce analgesic effects. Analgesia, again, just meaning pain relief. It modulates analgesia produced via mu receptors, so it basically is working in conjunction with mu receptors to produce its analgesic. And it may mediate anxiety and depressive-like behaviors, so there are some potential treatment methodologies here for depression through the delta receptor. And then we have kappa, which is really interesting, a really interesting opioid receptor because it regulates pain perception, gut motility, and dysphoria. So it causes dysphoria, which means that it makes people feel very uncomfortable. It can also mess with your water balance, feeding, and temperature. And very interestingly, salvia, which is, I don't even know if anyone knows about salvia anymore, but salvia, like 15 years ago, was really popular because it was a hallucinogenic drug that you could get from gas stations and like smoke shops. And basically it was like it had a really strong, like, it made you trip hard, and it was unknown for a long time that it was causing its hallucinogenic properties through kappa receptors. And actually the guy that made salvia was a big chemist and stoner type of, or I don't even know what you call people that are like really big into hallucinogens anymore, but he was really big into psychedelics, and he didn't believe that it worked through the kappa receptor because he thought that opioids were bad, and he thought that hallucinogens were good, right? So you have all these like weird factions of people that think certain drugs are bad, certain drugs are good. But anyways, this guy discovered that it actually does work through opioid receptors because he smoked salvia and then took a opioid blocker like Narcan and immediately was not hallucinating anymore. And so he was very upset about that because it meant that salvia does indeed work through opioid receptors, specifically through kappa receptors. So that's kind of interesting. So endorphins, you may have heard that from runner's high or whatever, are endogenous opioids. Okay, so endorphins enkephalins and dynorphins are all drugs or chemicals or neurotransmitters that are produced in your brain that work on opioid receptors. And although we knew about opioid receptors and these kind of opioid chemicals before we knew about endorphins, which is why we call them endogenous opioids instead of like the other way around. Maybe opioids should be called exogenous endorphins or exogenous opioids. But in any case, we have endorphins, which act on the mu receptor, and it produces analgesic, reinforcement, feeding, cardiovascular, and respiratory depression, just like other drugs that target the mu receptor. We have enkephalins that act on the delta receptor, and its function is, again, analgesia, reinforcement, cognitive function. It has effects with smell and motor integration. And then we have dynorphin, which acts on kappa receptors, and it causes neuroendocrine function, water balance, feeding, temperature control, dysphoria, and analgesia. So you should know that which endorphin, enkephalin, and dynorphin, which receptors they work for. You should also know roughly what the receptors are doing. So I'm not going to ask like super hard questions, but I'll probably ask about salvia and something like, it's false that no opioids cause hallucinogens. Or I'll say heroin produces its analgesic properties through which receptor, that kind of thing. Okay, so opioids increase dopaminergic release, and we'll go over this in greater detail about whether or not this is true in our substance abuse lecture. But the canonical view is that drugs of abuse are addictive because they increase dopaminergic release in the mesolimbocortical pathway. So we have our brain here. I think we went over this in neuroanatomy, but we have two main nuclei that produce dopamine. We have the substantia nigra, which is a black nucleus that sends dopamine to your striatum and helps you control movement. And then we have the ventral tegmental area, which is a nucleus that sends dopaminergic projections to also the ventral striatum, but your nucleus accumbens, which is the ventral striatum, and the cortex. So the mesolimbic pathway is the ventral tegmental area to the nucleus accumbens, which is over here, which is the ventral striatum. And then we also have the mesocortical pathway, which is the VTA to the cortex. Now, I'm calling it the mesolimbocortical circuitry because oftentimes these three brain regions, the ventral tegmental area, the cortex, and the nucleus accumbens, are all communicating back and forth with one another. So that's why it kind of is all lumped into mesolimbocortical, but you can get more granular and just say mesolimbic, which means VTA to nucleus accumbens, or mesocortical, which means VTA to prefrontal cortex. When it comes to the rewarding or hedonic effects, the substantia nigra is not normally talked about as much. Like the nigrostriatal pathway has more to do with motivational aspects compared to reward. So I'm not going to ask you about the substantia nigra here. We'll talk about the substantia nigra when we talk about Parkinson's disease. But as far as the rewarding aspects of all drugs of abuse, and including opioids, that is thought to be mediated by the mesolimbic and mesocortical pathway. For sure, that's going to be a question. You should know that mesolimbocortical is referring to all three brain regions, the VTA, the nucleus accumbens, and the cortex. And you should know that mesolimbic is referring to VTA to nucleus accumbens, mesocortical is referring to VTA to PFC, and the main neurotransmitter that's being released here is dopamine, because that dopamine is produced in the cell bodies here in the VTA and then transported and subsequently released synaptically in these downstream neurons. Okay, so psychostimulants primarily work on dopamine transporters. Psychostimulants are drugs that produce strong sensomotor activation, which means your ability to move around, characterized by increased alertness, arousal, and behavioral excitation. These drugs manipulate dopamine transporters. Cocaine blocks dopamine transporters, whereas methamphetamine not only blocks dopamine transporters, but reverses dopamine transporters and floods the synaptic cleft with dopamine. So that's why drugs like methamphetamine are typically thought of as being more potent than drugs like cocaine, because not only are they blocking the reuptake of dopamine, which if you remember from our previous lectures on synapses, DAT or dopamine transporters are the reuptake mechanism that stops neurotransmitter activity. So if you remember, neurotransmitters are inactivated several ways. One of them is through reuptake, you have diffusion, and you also have metabolization through enzymes. But cocaine binds to the dopamine receptor and doesn't allow, or the dopamine transporter, and doesn't allow reuptake of dopamine. Methamphetamine actually binds to the dopamine transporter and then flips it. And then what that results in is dopamine transporter now taking dopamine out of the vesicles and the intracellular space and pumping it into the extracellular space, which is really cool in my opinion. These drugs are called stimulants because they increase behavioral output, but they are also strongly activating the central nervous system, both behaviorally and neuropharmacologically. So, I mean, it's like they're called stimulants because obviously you're running around all over the place, but the brain is actually being, stimulated here. So these are all illicit forms of psychostimulants like cocaine and crack and meth. And crack is cocaine, okay? So I don't think I'm going to ask that on the exam, but just for your own edification, if somebody is talking about crack or smoking coke, what that is referring to is crack. And vice versa, crack is cocaine. So the reason why that's important, it's not like, I don't know what people's view on the way I'm talking about these drugs are. I don't think drugs are good or bad. I think drugs are just chemicals, and they have benefits and they have negative effects also. But like the reason why the crack cocaine thing is so important is because of the kind of abuse that our justice system kind of used against low socioeconomic status individuals when crack, which is a lot cheaper and more effective than coke, powdered cocaine, is often in the 80s, crack was a poor person drug and cocaine was a rich person drug. And the narrative in the media was that, well, crack is this horribly dangerous, vile chemical that is going to make you into an insane person, whereas cocaine is bad, but Obama did coke, like who cares? But the reality is that they're both the same chemical. You know what I mean? Like crack is generally a little bit more effective and potent because you can smoke it and because you get more out of what you get more of the drug in your system and has a more rapid onset of effect. But it is the same compound. So the idea that our justice system would have different consequences, maybe I didn't even say that yet. The justice system actually had different laws on the books for crack versus cocaine, powdered cocaine. So, which is preposterous because people are doing the same drug, and yet some people are going to prison for 15 years for crack cocaine and getting a slap on the wrist for powdered cocaine. So that's why I'm very passionate about this, is not because I don't want people to do drugs, but what I do want is for our population to understand drugs, because drugs are such a big part of our population and our culture. So you shouldn't be going to prison for 15 years for crack and only for 3 years for coke. I mean, it's the same thing. Not only that, but prescribed psychostimulants have a similar mechanism of action as cocaine and meth. So Adderall is an amphetamine and works by the same mechanism that methamphetamine works, by blocking dopamine transporters and reversing those transporters. So the reason Adderall is used instead of meth is because of the strength. It's not as potent as methamphetamine is, but it also is the ability to make it have a different metabolic profile with extended release. So technically, meth could be prescribed for a lot of the same pathologies that Adderall is prescribed for, but the therapeutic index of methamphetamine is going to be far less favorable than the therapeutic index for something like Adderall, where it's much more regulated and controlled, and you can reduce its onset of effects because of the way that you formulate the pill that you're taking, as is done with extended release. But again, the main point here is just that the drug works the same way that meth works. You know what I mean? Like, it binds to dopamine transporters and reverses those proteins to release dopamine. Now, Ritalin, on the other hand, is totally different class of drug that we'll talk about when we discuss ADHD and other psychopathologies, but Ritalin also works kind of similarly in blocking, dopaminergic activity. So then we have antidepressants. So antidepressants is referring to a large grouping of drugs that are named because they are prescribed to treat depression. So it's not like with opioids where we're naming them based on or referring to them based on their mechanism of action, which we do with certain things like SSRIs, MAOIs, TCAs, etc. But when somebody refers to antidepressants, you don't know which kind of antidepressant they're talking about. So they contain several different mechanisms of action and are thus further subdivided. So we have selective serotonin reuptake inhibitors, which are the ones that people typically think of. We have MAO inhibitors, which are monoamine oxidase inhibitors. So if you remember, serotonin is a monoamine, and that means that it's degraded by the enzyme monoamine oxidase. So monoamine oxidase degrades both serotonin and dopamine and norepinephrine and any other monoamine. So one way to treat depression is by increasing monoaminergic activity. And the way that you can increase monoaminergic activity is by decreasing the enzyme that gets rid of those monoamines. So that's one treatment for depression here. We have TCAs, which are tricyclic antidepressants. We have atypical antidepressants, which are a bunch of different types of drugs that just don't fit under any of these one categories. So one of them is bupropion or Wellbutrin, which also works, interestingly enough, by reversing dopamine transporters like amphetamines, but has a very different pharmacodynamic profile. So although a lot of these drugs work at the same, they have a similar mechanism, depending on their pharmacodynamic and pharmacokinetic properties, they will have different outcomes. And I'll ask that for sure on the exam also, which is that, like, why can drugs have the same mechanism of action and yet they can have a different subjective physiological or psychological effect? So I already basically explained this, I think, but SSRIs are selective serotonin reuptake inhibitors, and as the name suggests, they block SAT, which is serotonin active transporters, resulting in an increase in serotonin in the synaptic cleft. I think we talked about that. This is very similar to how cocaine works, except instead of working on dopamine transporters, it's working on serotonin transporters. And also, cocaine and amphetamines and methamphetamines are also working on serotonin transporters as well, most likely. MAOIs, which I already explained, are monoamine oxidase inhibitors, and as the name suggests, they degrade monoamine oxidase, which is an enzyme that degrades neurotransmitters that are part of the monoamine class, which includes serotonin and dopamine. Therefore, if you have a MAOI, a monoamine oxidase inhibitor on board, oh man, look at this terrible typo here. I'll fix that and re-upload that for you guys, but what an embarrassing blunder on my end. You're going to have less of the enzyme that degrades serotonin and dopamine, and thus more of these neurotransmitters in the cleft. So I think I explained all those already. We are at an hour and like 20 minutes or something like that. So I think that we have reached the end of psychopharmacology. I know that this is a pretty dense lecture. There's a lot of content you need to know. I'll have the study guide for this, and you guys will also see the questions on the quizzes before you take the exam, so you'll have a better idea of what you need to know about. But the things that I spent a lot of time on, belaboring the points are generally what I'm going to be asking questions about. So that was psychopharmacology. Best of luck, and I hope that you have enjoyed this lesson.